The biggest question today in myeloma is can we cure this disease? So clearly we are making a lot of progress getting patients into very deep remissions from the disease with all the combinations, transplant and so forth. But we still don't have a very good proof that we can cure the disease. And the question that comes up is maybe we are acting too late. We are already making some changes to that paradigm by the new response criteria. Now patients are getting started on treatment a little earlier before something bad happens. But the fundamental question is, are we still too late? Should we be starting much earlier if you really want to cure this disease? And there is some evidence that points in that direction. We know that some of those genomic changes that happens in the myeloma cell accumulates over time, and by the time patients get newly diagnosed myeloma and later on relapse myeloma, there are a lot of changes in the genome. But in the smoldering phase, we probably don't have as many changes. And one of the advantages, so to speak, in myeloma is that patients usually have this 10 to 15 years of monoclonal gammopathy of undetermined significance, and then there's a smoldering phase before they get active myeloma. So it gives us a lot of opportunity for intervention. So the question is, can we actually use some of these new, very effective drugs and give it to patients early on before they have symptomatic myeloma, and actually change the natural history of the disease and maybe even cure the disease so they may never get active myeloma? So what we are really looking for is, can we take a smoldering myeloma patients and make them MRD negative and keep them MRD negative even when they go off treatment for a prolonged period of time? So the tools that we would like to employ is a combination of the new drugs. So the trial that we are designing, it's a phase 2 trial. So it's going to have two groups of patients, one who can go through a stem cell transplant and one group of older patients who cannot go through a stem cell transplant. And these patients are all going to get a combination of new drugs. Right now we are thinking about maybe combining one of the new proteasome inhibitors with lenalidomide, dexamethasone, and daratumumab, which is a new monoclonal antibody. So patients would get 4 cycles of this treatment. Patients who can get a transplant then go on to get a transplant. Who cannot get a transplant will get 4 more cycles of the same treatment. Once they complete that consolidation part, we will go to what we call an intensification phase, where they get 4 more cycles of the same treatment, but with some modifications in the dose so that they can continue to tolerate it. So we are looking at about 12 months of treatment, and then patients get a much lower dose of some of these drugs, what we call a maintenance phase, for about a year. So we are talking about 2 years worth of intense therapy in patients who have high-risk smoldering myeloma. And then at the end of this, we're going to watch every year, we're going to do MRD testing to see that if we have managed to eliminate all the myeloma cells, and can we keep it that way. How do we know if we'll have success? I think it'll take a little bit of time. In the short term, we can prove that it is safe and that we can get people to MRD negative. In another 4 or 5 years, we look back and see if all those patients actually stayed MRD negative the whole time, in which case I think we can say that yes, now we have made a definitive step towards cure. So I think that is the whole goal of the ASCENT trial, is to kind of push the envelope, see if we can actually cure this disease and by nipping it in the bud.